Good evening, everyone, and welcome to the Second District's Health and Wellness monthly webinar tonight. I will again step in as your host tonight. Our great brother Kelvin Ampofo couldn't be with us tonight, so I'm going to sit in his stead. But tonight we had exciting topics and a lot of things we want to talk to you guys about tonight. A lot of it is advocacy. We're going to have a good time talking about things to do for your health. This is several different things going on this month. There's Esophageal Cancer Awareness Month, National Minority Health Month, Alcoholic Awareness Month, and Health Advocacy Month, amongst anything. So we're going to do what we always do. But before we get to that part, I just want to say to you, the opinions that we hear tonight and expressions that we talk about are the opinions of those people themselves, not the fraternity. So with that, I will head over to Dr. Jedan Phillips, who's our chairman, to give his opening remarks.
Greetings. Welcome, everyone. Appreciate you coming in. And more importantly, 78, appreciate you being that 5-tool player that whatever position you are needed in, you are able to jump in, my brother. Thank you so much. Yes, tonight we are talking about Black health advocacy. And one of the things that goes into that topic is the discussion of prevention. I think we have seen during this pandemic that prevention has been something that has been revealed as a vulnerable space for our community when it comes to their medical care. Again, how many people have a primary care physician? So if they have a health crisis, how do they proceed? Another thing that we're going to touch on tonight is how can you be the best patient for your doctor visits that you need to be so that those visits cover all of your needs? How many times have you or maybe your spouse gone to a doctor's appointment and they come home to you and you ask them question 1 or question 2 and they don't know because they did not get that information when they went into their appointment? So we're going to be talking about some strategies that can make you able to maximize the use of your doctor's appointments. So I'm really excited to hear what the conversation is going to be with the brothers tonight on our committee. So looking forward to it. Thank you.
Thank you so much, Dr. Phillips. Now we'll have Dr. Cedric Guyton, who is a doctor of pharmacy, come on and give his opening remarks. We can't hear you, brother. I know you got a lot of good knowledge in part, but we can't hear you, my brother.
Good evening. It is really great to be back here with you all on the Second District Health and Wellness webinar. It's been my great honor to serve this fraternity in this entire time throughout COVID as we pivot now to the prevention and treatment of disease and disease management inside of our communities. We want to really make sure we focus on this month's National Minority Health Month of health literacy. I'll try to help with providing some information on some tools and understanding and statistics on what and how important health literacy is to our communities. Again, great honor to be here with 78 and 88. I'm just overwhelmed with the continued support that we've had from our fraternity and our communities as a whole.
Thank you so much, Brother Dr. Guyton. Now we'll hear Brother Dr. Wingfield's opening remarks, please.
Hi, good evening, everyone. It is once again an honor, a privilege to be here to endow and share more knowledge as we move forward. This has been a monthly event, and the response that I get regarding this event is just phenomenal. We need to continue to get the message out. We need to continue to educate our community, discuss how we need to approach our doctor's visits. That's one of the things we'll certainly talk about tonight, to talk about disparities that we see in terms of whether it's we are not being treated the same when it comes to healthcare. So there are some pearls and things that we need to take into consideration when we see our physician. Certain things regarding implicit bias and how we're viewed and how you're viewed when you walk into the room. And as we learn more about this, we can become more of an advocate for ourselves in our own health. So it's a tremendous amount of knowledge that we can impart. Looking forward to the exchange and the dialogue. I, again, am an interventional cardiologist, treating heart disease, peripheral vascular disease, trying to prevent amputations, trying to prevent strokes and heart attacks and all those things. So plenty of information here. I'm excited. I'm ready to go. Thank you.
Thank you so much, Dr. Wingfield. Brother Dr. Isabell, would you give us your opening remarks? Can't hear you. All that good knowledge is coming out, brother. We can't hear you.
Good evening. Once again, glad to be here. I'm Dr. Lee Isabell, board certified internal medicine, primary care physician, as well as I do HIV, Hep C. As we know, April is National Minority Health Awareness Month. Was first initiated by Booker T. Washington in 1915 and made nationally in 1951. And preventive measures, well-being, disparity. I'm glad to be here. Thank you.
Thank you, Dr. Isabell. Dr. Plummer, why don't you give us your opening remarks?
Hi, I'm glad to be back again with these great brothers.
Oh, we lost it. Well, we wait for him to come back on. Dr. Ford, would you give us your opening remarks?
Yes, good evening. I'm Dr. Kevin Ford. I'm internal medicine physician practicing in Prince George's County, Maryland. It's always great to be amongst the mega men here, sharing information about health. Health literacy is so important, and I can't wait to get the conversation started. Thank you.
Thank you so much. So, well, let's just jump right into it. Well, here's Dr. Plummer. Go ahead and give us your remarks, Dr. Plummer, before we jump into it.
My name is Dr. Christopher Plummer. I'm board certified in OBGYN and in maternal fetal medicine. I specialize in women's reproductive organs and also in high-risk pregnancies. Just want to make sure we even the playing field for women and also reduce maternal mortality. I'm going to have a nice discussion here with the brothers about making sure that you're an advocate for your for your health, and also that you make sure that you follow up with your primary care for your primary care screenings and vaccinations. Thank you.
Thank you so much. So let's just get right into it. What is this? What is all that's about? Talking about advocacy and health, national minority health. Is advocacy just something that physicians do? Is advocacy involved for everybody? What is the whole idea of advocacy? Dr. Phillips, you want to take that one for me?
Well, again, when we talk about advocacy, I think the responsibility or onus is spread out. I think as a primary care physician, if I have a patient that I'm sending to Dr. Wingfield as a cardiologist, again, I know if I send him to Edward Wingfield, I'm not going to have to give him any prep information because he's going to be very, very thorough and make sure that his message is heard. However, every doctor is not like specialist is not like Edward Wingfield. You're going to have to make sure you send them with some marching orders. They need, those marching orders because they help provide confidence. I think also to the point that Dr. Guyton made, which is making sure that patients demand comprehensive communication is also important because the issue of health literacy is significant. And I find that when a provider encounters a patient that has some knowledge and wherewithal, we try to take some additional steps to make sure that we're better understood.
So, Dr. Wingfield, you're an individual cardiologist specialist, but, health advocacy doesn't stop with the primary care physician. So, when people come to you, what are some of the things that you would expect to have when a patient comes to you from a primary care person?
Right. And as a cardiologist, that's what we deal with in a lot of cases are referrals from a primary physician, because they may have concerns about, one, the patient's family history, two, about certain risk factors that particular individual may have. So as you approach your visit with a cardiologist, understand exactly why you're seeing that cardiologist. My point to most people, you need to see a cardiologist if you have any one of those risk factors, whether it's high blood pressure, if you have a diagnosis alone of high blood pressure, whether you have a diagnosis alone of diabetes, whether you have kidney disease, or if you have a family history. If your father had a heart attack in his 50s, you should start seeing a cardiologist in your 40s. So if you have any of those risk factors, then certainly you should see a cardiologist, because so much of this goes undiagnosed, especially in the African-American community. And what is known and what is a common fact is that we tend to present later with much more advanced disease processes. So by the time you end up getting in there to see the cardiologist, we're talking about amputations as opposed to opening the vessel or starting a medication. So those are the things that one, we have to certainly be knowledgeable about. But as Dr. Phillips stated, that if we approach our visit with a physician with the wherewithal and the knowledge, bringing our medications, bringing our family history, bringing our important and pertinent data to that visit, we're going to be taken much more seriously and have a higher quality visit. So these are the things that we really want to keep into the back of our minds, and we can talk more about specifics in terms of what should you expect from your cardiologist, right? We're here to serve. We're here to treat you. So when you go in for that visit, the expectation that we have, or you should have as a patient, is that this doctor is here to answer my questions, to treat my disease process, explain the side effects, explain the disease process to the full extent, and the risk and benefits of any procedures or medications that you may be taking.
Well, to that end, it's a good question raised in the chat. Is like, why, when some hospitals are giving out 1-day free medical care and screening, why don't we take advantage of it? What is the situation? What is the barrier to Black people seeking these free care situations or free screening situations? What do you think are some of the factors that anybody can take this particular question?
Well, I think we always go to distrust of the healthcare system. And that's somewhat unfortunate. So we really need to try to change our approach in terms of how we view medicine. We have to be more of an advocate for our own health and understand that we have control of our own destiny. Medications are not always bad. The fact that I'm being placed on a medication does not mean that I'm on it for life, or, it's going to hurt this or that. So if we understand the types of questions that we need to ask and the benefits that these medications may provide, then I think that we could start to move the needle towards better health overall.
I think another thing to add on to what Dr. Wingfield said is a lot of us are in survival mode still. A lot of times when you're in survival mode, you could be tired, you could have a little bit of a headache, and you still got to go to work, and you're still going to go to work. And that tired could be your sugar's over 200 possibly, or that headache could be your blood pressure's high. But I think it speaks to how a lot of us in America or around the world live in a reactive way when it comes to their healthcare. And as I've learned as a homeowner, reaction could cost you a whole lot more than prevention does. And I think the same stands for our bodies and our health.
You raise interesting. Go ahead.
Well, I was going to just chime in. Another reason that a lot of patients don't go is just fear of knowing. Yeah. Right. They don't want to know whether they have, something in their colon or where their arteries are blocked. They just don't know until it gets too late. And then all of a sudden, like Brother Phillips said, not knowing will cost you a lot more in the long run. And so we have to make sure that people understand that ounce of prevention and screening and early detection is something that is so important for everyone's health.
Go ahead.
As Dr. Ford just emphasized, the prevention side of it, the public health prevention side of it, is very essential. Working in many underserved communities, especially in the Native American reservations, it was clearly understood that providing their adequate information, making sure they understand what prevention is and why is it important, continually to providing the correct message about how important it is for you as a community to take care of your health. The reinforcement of the health information that's being provided. In this country, it's estimated that only 14% of the United States understands health literacy, understanding the services, the information, and the why you should be screened. I think when we go back to advocacy, is twofold. We have to teach our patients, as I do, and I sit and I screen patients, I give out medications and any reservation. I teach them to advocate for themselves when they go to the doctors. I teach them to ask the questions. I teach them to take the information. You be your best advocate first. Your provider can help you once they understand the level of literacy you have about yourself moving forward.
Well, let's look at it from a different perspective. That's a very good point that you make, Dr. Guy. But what about a lot of people out there that say, "Well, I just don't feel like being bothered going seeing no doctor. I don't have time for this," And say, for instance, well, I'm not gonna go see my primary care because I'm going to go see my OB/GYN doctor. What about those patients? You want to comment on that, Dr. Plummer?
Yeah, I mean, some OBGYNs, they might do primary care, but primary care is so vast now that an OBGYN specialist has so much to do with just reproductive of gynecology and obstetrics that they don't really have the time to do the basic primary care. So when they come and see me when they're pregnant and they haven't seen their primary care doctor, it becomes an issue when their diabetes is not well controlled, and when your diabetes is not well controlled and you're pregnant, it can cause complications in the development of the fetus. It can cause complications in the pregnancy. You could develop, severe high blood pressure, preeclampsia, early delivery. And premature delivery can cause a lot of issues with the baby and also cause a lot of long-term neurological issues. So it's very important for them to follow up with their primary care doctor, optimize their health before they get pregnant, or always keep their health optimized because they never know when they're going to become pregnant. And if they do have an issue, to come for a consultation that we can just make sure that we have a plan that you get yourself optimized. And when you do get pregnant, we can start to work on you having a successful pregnancy. So that is the main struggle that we do have with people not following up with primary care and their vaccinations and screenings.
Well, Dr. Isabell, what about people that don't have access to care? They're very limited. They don't want to go to the clinic because they feel the stigma. They don't know what's going on with, like, I don't want to go to the clinic because they don't take care of Black folks there like they take care of everywhere else. What about access to care, Dr. Isabell? Any thoughts on that?
Thoughts on that? Yes, the healthcare system over the last couple of years has changed drastically. You have these big hospital corporations that are actually getting bigger. You have primary care doctors that are now part of these big groups where they do serve underserved communities, as well as patients that have insurance. That as well as patients that are self-pay. They also have some urgent care facilities, but these major hospitals do take patients that may not have insurance. So it's not always just the clinic, but I think that's a misnomer. You have to get over it because it's about your health. It's about taking care of yourself. And it's very important because a lot of times it's preventive. That you don't know what you need to be screened for. You don't know you may need to be screened for what age of prostate, what age of colon cancer. You may not know regarding your family history. And yes, there is a disparity. But the goal is for these hospitals, the health community is trying to work to close this gap.
So let's talk a little bit about those. You brought up an interesting point. Let's talk about those people that may not have insurance, may not feel like they need to go see anybody. Well, I don't have any insurance, so I'm not going to go and see a physician anyway. What are some of the things we as physicians can do to help direct those people to getting care that may not have insurance? Or they may have something like Medicare or Medicaid, and they think there's a stigma attached to having Medicare and Medicaid. Anyone want to take that one?
Sure. Again, you'd want to check on the resources in the areas. I know personally, I am a medical director of a free clinic that provides pro bono preventive care to individuals 18 and over in the area. I mean, I have people that come, I'm in Suffolk County in Long Island, I have people that come from 50 to 70 miles away, you know, to make sure that they are able to get access to that. I think, again, you know, that access is critical, because when you don't have an access point, what do a majority of people do? They show up at the emergency room.
Right.
And that leads to, maybe if you have a significant problem like a heart attack, you might not be able to get the proper care because somebody's coming there with a basic infection. So I think that, you know, that's one of the things you can do. A lot of times, if you're near medical schools or institutions, you may want to just Google free clinic. In addition to that, if you have Medicare, one of the most detailed exams is the annual Medicare wellness exam.
Mm-hmm.
So it is a very detailed exam that goes over every nook and cranny and detail of your health, including your functionality. You know, it takes into consideration your limitations, and it makes up a plan of action for you that we need to make sure you understand, so we have a plan moving forward. So with Medicare, I wouldn't be concerned, because I find that those exams are probably more detailed than the annual physical exam that you may get with regular private insurance.
Exactly. And as a pediatrician, I mean, I dealt with a lot of preventative health care. And in fact, that I had to deal with the growth and development of children, because if what I do as a pediatrician prevents maybe some things coming down the road, you know, and part of the advocacy that I did and access to care, if you, like you said, Dr. Phillips, if there is a free clinic somewhere out there, look for it, because believe it or not, you can still get your vaccinations at a lot of these free clinics. These vaccinations are given away free, so your child does not have to go without being vaccinated. There is always a resource for doing it. And please, please, please don't, you know, if you have Medicaid or you have whatever aid that may be given to you that you think is not the same as private insurance, think again, because Medicaid is no longer the one where someone is go down and then down and out, you know, and have no other means. They got to get Medicaid. Medicaid is for everybody. Medicaid is just exactly what it says, and aid to those folks who don't have regular insurance. And I know a lot of children are on Medicaid, and a lot of organizations, as Dr. Isabell pointed out earlier, a lot of these companies are now incorporating Medicaid, Medicare, and they're bringing them in under one umbrella, so that there's no distinction between you have Medicaid, you have Medicare, or you have private insurance on this particular corporation. So people, you know, you can have access to care. You just got to look for it, you know, and if you don't look for it, there's always somebody out there to help you. I do a lot of things with my church. I do a lot of senior ministry education stuff for our Medicare patients. And I also talk to communities about where their children can go. So there's always lots of things like that out there for you. So, you know, you've got this patient now, very first patient coming to see you, may have a laundry list this long. What are some of the things you can expect that patient to know and see when they come and see you, Dr. Ford?
Well, hopefully when they come in, that your staff has already prepped them when they call for the appointment, right? To tell them to bring in all their medication, and not the pills, because we don't know what the blue pill is and the red pill, but bring the bottles, or at least take a picture of the front of the bottle so that we know exactly what you're taking, what dosage you're taking, how frequent you're actually taking the medication. And so doing that. The other thing is, our staff tries to get them to fill out the form ahead of time so they know their family history, because it's important to know your family history, and then we can assess when you would need some of your screenings. Let's say someone that has a history, a father or other first-degree relative, brother, sister, would say colon cancer. We know that, hey, I can't wait. If they had colon cancer at say 50, I can't wait to screen you at 45. I have to screen you early. I got to screen you 10 years beforehand. So those are important things that, you know, we need to prep the patients ahead of time, as far as bring your medicine, know your family history, any other surgeries that you've had, because all these things make a difference on how we're actually going to treat you.
Yeah, I think another important point is, what exactly are your symptoms? Write down what you're having. What is it that's bothering you? Do you have hoarseness? Do you have swelling of the feet? Do you have shortness of breath with climbing the stairs? What are some of the things that people need to pay attention to that, often in the minority communities, they always say, well, it's just a little touch of this, a little touch of that. What are some of the things that you folks need to be with, some symptoms they need to be aware of? And maybe write down and keep an eye on these things and be prepared to go and check them out. Anybody want to take that question?
Well, I think any symptom that persists for longer than a couple of weeks is something to be concerned about. Firstly, a lot of times, we'll tolerate aches and pains. Oh, I get a little pain in my chest. That may be something. I think, again, chest pain, headaches, dizziness. If you fell down, as we get older, yes, when we were younger, we never fell, maybe, but as we get older, sometimes we could take an awkward step. That step could mean that there may be a bigger problem. Any changes in your weight, hey, I lost 100 pounds and I didn't plan on losing weight. Difficulty sleeping. Those are some symptoms that I would, recommend somebody mentioning if they came up against. I'll let the other brothers speak.
Come on,
I think
brothers.
one thing that, I'm sorry. I think one thing that I've seen, and I'd like to highlight, are stroke symptoms, as well as arthritis. Okay. Now, when I talk about stroke symptoms, I've had a good number of patients, several patients who've had symptoms of a stroke, whether they can't lift a coffee cup, they're having numbness and tingling in the face, unable to get up from a chair, this weakness or slurred speech that may come and go. That they sense, and they don't recognize these symptoms as a stroke. I've had a patient where he was having these symptoms. His wife said, go upstairs and you're just tired. Go upstairs, lay down, take a nap. Full blown stroke. Okay, where he's lost the ability to move the entire left side of the body. So in a lot of cases, it's symptom recognition to say that, look, if I have a facial droop, or if I have difficulty lifting something or difficulty speaking, that these may be symptoms of a stroke. If I have a massive headache that's out of proportion to the typical headache, that this may be something that I really need to be aware of. Okay. And then number two, arthritis. A lot of patients will complain of joint disease or pain in the legs, but lo and behold, it's peripheral vascular disease, meaning that this is actually blockages in the circulation that could lead to amputation, loss of limb function. So those things that you kind of push through, oh, it's just my arthritis flaring up. But no, this is something that needs to be diagnosed, because peripheral vascular disease it's underdiagnosed across the board, but in African-American communities, it's even worse. And the predictability of death, essentially, after an amputation, in some cases, is within 6 months. So if you have an amputation, the mortality in 6 months is about 50%. Okay, so it's really striking in terms of the numbers if you proceed to an amputation. And then also one of the things that I always look at is those patients who do undergo or have to have an amputation. What is the workup involved in that prior to that amputation? A lot of times these patients won't have the typical workup, especially in certain communities where they don't have an angiogram. It's just they go straight to amputation. So with that said, just recognizing the symptoms, whether it's chest pain that's out of proportion to what you had in the past, you need to seek medical attention.
So let's talk about hypertension and what are the ignored symptoms of worsening hypertension that we as minority people often ignore. Dr. Isabell, you had something you wanted to say earlier. Can you chime in on that?
I was going to say something earlier, but to answer one of the questions, someone mentioned it was like 50% of the family history is known. Yes, that's true. But I've seen in office sometimes that, I forgot to tell the nurse this, I forgot this. And then if you have a good rapport with the patient, sometimes you can get more history that they didn't realize that they had. Regarding hypertension, a lot of times, unfortunately, some people do not have any symptoms of high blood pressure. So that's why you should make sure you get your annual checkup, see your doctor, or sometimes if you just go at your a church event, health event, or sometimes in the pharmacy, just check your blood pressure because you may feel fine. And that's why everyone knows sometimes hypertension is considered a silent killer. All right, so say you do have symptoms. Sometimes you can get a headache. Some people may get a headache, or they may just feel even fatigue, or they may feel their pulse or palpitations. Their legs may be swelling. It could be a sign, or they have morning headaches. But though, because the problem with high blood pressure, it can lead to kidney disease as well as heart disease, because kidney disease is very high in the Black population. A lot of there are more Blacks, unfortunately, on that may end up on dialysis than Caucasian, and we're the small percentage of U.S. population.
So one of the things that, often came up during a visit with my patients, they say, well, if I got to ask you this, or they don't understand anything. So one of the things that what we doctors do a lot is at the end of the visit say, now, do you understand? Can you tell me back what I said? So one of the things I always advocated for people to do is, even though I'm talking, I'm examining your child, write down your questions so that you won't forget it before you leave the office with me, or write down your questions before you come to the office and see me. So, excuse me, for example, now how much am I supposed to give my baby of this particular medication, and when and where do I get this medication from? What happens if I take too much of the medication? I mean, these are simple questions, but these are things that you need to do because, the doctor-patient relationship is no longer a hierarchy. It's a partnership, if you will, because you and your physician are both involved and have to take your best interest is your overall health. So, as I said, I always tell people, write down your questions, write down before you come to the office, write down during the visit, write down, everything you don't understand. So when you leave that office that day, I want you to understand everything we talked about, and any symptoms you brought up. I hope, as Dr. Isabell said, I hope these symptoms are addressed because a lot of them ignored. It's just like there is nothing else going on there. So, but anyway, Dr. Plummer, tell me about some of the things that women don't have access to, or what are some of the things that you see that women's health is affected by, access to care or poor advocacy, or what?
Well, from what I see, that a lot of women are caretakers of their children and also caretakers of their parents. So one of the things, the problem with access is that some of these women might work shift work. And with shift work, it's very difficult for you to get time off for you to go to your doctor. And a lot of them have to make a decision about not getting paid or being able to go to the doctor. And some of these offices now have kind of changed. So there's been a large amount between Monday to Friday during work hours. And a lot of people have to work at that particular time. So they're unable to get to the office or to the clinic at that because they have to work. And there's no help out in the political system with giving people paid time off so they can go to their doctors. So a lot of them have advocacy saying that they want to make sure every woman that gets pregnant can carry to term, but yet they don't really give them time so they can go to their doctor, their OBGYN or whatever for their regular visits and being compensated for their job just for those visits. So I think that is a barrier to care. And the other concerns when women are pregnant is if they have a severe headache that's not going away. That could be a sign of high blood pressure, worsening preeclampsia, and that could also be a sign just before you start to have a seizure, especially when you're a pregnant woman. And then the other aspect is women that are either pregnant or on birth control, and also that smoke. If they get a lot of swelling, especially in one leg or even in both of their legs, one of the concerns that you can have is a clot that's developing in one of your lower deep veins in your leg. And when that sometimes breaks off, it can go into your lung and can cause death. So that is a very serious thing that you can't really ignore. You should, call or go to your doctor for evaluation.
Thank you. So we've heard a lot about, primary care and specialty care in terms of Dr. Wingfield, but let's talk about the public health aspect of it. So Dr. Guyton, what are there things in the public health sector that can help us out, can help us out with our minority people getting access to care? What are some of the things that may be available that you may be aware of?
So one of the main things we want to help our audience is to find when we talk health literacy, you're talking personal health literacy and organizational health literacy. In the public health sector, one of the things we focus on, specifically with some of our free clinics, some of our underserved communities, is our organizational health literacy aspect, where we as organizations provide information, how to use that information, how to use your health access, how to use your access to your information, and also how the services that we provide can inform your health decisions. One of the main things from a public health perspective is the overall organizational perspective on communities, communities of care. We talk here about the individual doctors and how they practice, but it's always a continuum of care because you include the doctors, the nurses, the pharmacists, the social workers. In the public health perspective, we utilize the entire team approach. Looking at Healthy People 2030, we wanted to look at how we're changing some of our buzzwords when it comes to literacy. We're moving away from use of health information. We're moving toward use of health information rather than just saying understanding it. We want to make sure our patients understand how to use that information, how it can inform a decision, how it can inform a community approach to the decision, how HIV prevention, hypertension, those things, a diet, exercise. We want to make sure they understand how to use that information. Also, we want to focus on making sure that our decisions are well informed rather than appropriate. So well-informed decisions, again, goes back to the information, services, and how they access it, and the team approach of doctors, nurses, as well as pharmacists. In a community aspect, I will see patients more often than a provider will. So having the continuum of care for a patient, having the same level of literacy, same level of interaction about your healthcare, the number of resources that can be provided is essential in a public health approach. And we want to make sure that we have to acknowledge that it is a public health need. Health literacy is essential to public health. That, therefore, each organization should incorporate public health literacy in their approach as they move out, as Dr. Phillips talked about, large hospitals, large organizations. As a component, they know saving money by doing prevention is essential. And a component of that should be how we teach our patients and inform our patients about health literacy.
I think another action or avenue that can help with what Dr. Plummer was saying as far as a person who's working or has other demands is utilizing the technology. Telemedicine is something that is very much utilized, and it's amazing how many patients are not aware of it. So I agree with you, Dr. Guyton. I think we've got to be on the message of providing our patients with that information so that they're able to utilize it, and telling them and making them aware of that, hey, if you got to work, you know what, we can do a telemedicine visit. I've done many a telemedicine visit with someone who was on lunch from work, or they might have been in the closet at work or something like that. But again, that what it does by doing that for that little 10, 15 minutes, they still get a refill of their blood pressure medicine. They still stay on their diabetic medication or get an opportunity to discuss a test result. So using the other technologies that are available, and they're available to everybody. Some people in our communities are not even aware that that is a choice for them. So I just want to add that.
Dr. Phillips, you hit a nail on the head. I was going to comment community resources, understanding where they are, how to utilize them, and that they're also for you. They're not just for the other, they're for you and your communities, especially our minority communities, where 60% of them only believe their health is important. Doing something about their health is important. Giving them the resources can advocate and take them out of that pre-decisional component into making a decision about going into action on their health.
And we also must help them navigate the system, because a lot of patients don't understand the system going from point A to point B. They go in and see Dr. Ford or Dr. Phillips or Dr. Isabell and say, well, you need to go see an endocrinologist. You need to go see a cardiologist. We need to help them along that process there. A lot in the old days, what would happen is that you hand out, well, here's a written referral, go see Dr. So-and-so. But this day and time, we have the technology, as you brought up, Dr. Phillips, pick up the phone, or the patient can use their electronic device to make, to pre-populate, as which one of the brothers talked about, pre-populate information to take to that doctor to be prepared for. Learn about that particular physician, learn where he's at. You can always use your Google Maps. Like, I know where this office is. What can I utilize to get there? Can I utilize the public health system? Public services like buses, or can I drive there, or can I get a friend to take me there? So we need to make sure we advocate helping them navigate the healthcare system. That's one of the biggest things I saw in my limited time practicing internal medicine early on, that helping them navigate the system was a very difficult point. So anyway, so let's talk about prevention again. We know this whole thing that we talk about every month is prevention, and this being National Minority Health Care Month. What are the biggest things that we need people to take home from this in terms of prevention and preparation for their first office visit? Anyone want to take that one?
Well, prevention, there's so many different things that we screen for, right? Prevention. We're talking about, for men, prostate cancer, right? Getting your PSA tests done. Women, we're talking about mammograms, right? For screening for breast cancer. Usually we start around 40 for that. Some people say a little later, but I think 40 is pretty accurate. For Dr. Plummer, talking about women in cervical cancer screening, pap smears. So there's multiple different screenings that we can do. But the key is you have to go into the doctor so that they can assess you and get screened at the appropriate time to prevent illness or catch illness early enough where you can do something about it. And I think those are the things. Even lung cancer screenings now, patients that have smoked more than 20, what we call PAC years, and they're 50 years old. If we catch lung cancer early, you may have a chance, right? So there's so many different other screenings, and I'll let some of my other colleagues talk about some things they want to talk about.
To add on to the first, when you go for your annual checkup, or if you seen the doctor for the first time, we mentioned family history. We also screen usually for diabetes. We screen for cholesterol. We also, depending on your age, we call them the baby boomers. At one time, you also screen for hepatitis C, because that can, the population not know that they may have hepatitis C. That can also affect the liver. So that's also a screening. It's also recommended, but you can opt out, that age 13 to 64. Everyone should know their status for HIV. You should at least once in your lifetime get screened for HIV. But if you have high risk factors or risky, habits, should be screened more often. We mentioned lung cancer screening. Now majority of insurances, they call it a CT lung scan. They are covering that now, and to early detect lung cancer. And we mentioned colon cancer, which could be preventive, knowing the history. That's another screening. And then not mention, if you have smoking history, you should know sometimes you can be screened for abdominal aortic aneurysms, because smoking increases that risk. And then those are the basics. And then sometimes less common things you may ask with the family history, where somebody may also genetics or other things you may think of looking for. But yes, family history is important. And just as you see your patients more and more, you get to know them. Hopefully they get to know you, and you develop a good relationship where they feel comfortable with you. Also, we forget about screening. We do screen for mental health and
Yes.
depression, which a lot has been undertreated in the medical field.
Yeah, you bring up a good point. Before I get to that point, there was a question is in the chat is when should you have when you have blood work done, do they routinely screen for HIV?
Well, it depends. It depends on your doctor. A lot of doctors, there's some that don't. It's supposed to. I tried at 13 to 64. I do, but there's a lot of doctors that doesn't even come up unless you ask for it. It's supposed to be the CDC guidelines, but it's not always followed.
Just only usually in pregnancy, and that was one of the reasons why we were able to reduce the transmission from the mother to the fetus, because of everyone being screened early for HIV, and then can be treated if they're positive to bring down their viral load to undetectable, so it reduces transmission. One of the things also that we also talk about is to reiterate trying to get rid of bad habits or picking up on dangers. Like I think Dr. Boykin probably screens to see if there's guns at the home, because that can also lead to a lot of issues. We also like to screen to see if, smoking. Because one of the things, smoking, if they stop smoking, there's a lot of diseases that can really be prevented. And I think Dr. Wingfield could also attest to that, especially with, vascular health. And also alcoholism. Alcoholism can cause a lot of malformations in the fetus. So that's one of the no-no in pregnancy. But still, alcoholism could cause a liver disease, heart disease, and mental, and decline in mental health. So those are other things that we also can talk about when you come in for your doctor's visit, and they could reiterate good, healthy health habits.
We didn't talk about substance abuse, and this is also Alcohol Awareness Month, so there's some of the things that people don't go to their doctor for because they may have a problem with alcohol usage, or they may have a problem with substance abuse, and we as physicians are not out there to try to throw you under the bus. Our job is to help you get through your substance abuse problem or your alcoholism as best we can. So people need to understand that, if you have a problem, there are places, there are outlets, and there are physicians who specialize in substance abuse. There are physicians that specialize in alcohol abuse as well. And as Dr. Isabell said, we cannot forget that, we as Black people or minorities or communities of color cannot let the stigma of mental health bear us from seeking treatment, because mental health is not the same thing as that you're crazy. There's no mental health and craziness do not coexist in the same word. Okay, mental health is just another aspect of your health care. So I want people to understand that, if you have a problem with depression, if you have a problem with family history of bipolar disorder, or if you have a child that acts out, or you have anything that's, remotely related to mental health, please seek help, seek care for it before it's too late, before you get to the point where you feel like there is no help for you, because there's always help for you, and if you have mental health out there. So, if your doctor asks you to screen for depression, they're not trying to just set you up for anything. They're not trying to say that you're crazy. As I talked about, crazy and depression that don't equal the same thing. Part of what adult physicians and pediatric physicians do, we screen for depression on a regular basis, at least on an annual basis in the adult world, and in the pediatric world, we screen for depression. So when we ask you to fill out that form, it's not that we're trying to insinuate anything. We want to make sure that you get access to care early on rather than later on, particularly when, during the depression we had the pandemic, we have all these adolescents that are committing suicide. I should say completing suicide, because there's a difference between committing and completing suicide. Suicide is a thought, and when you do it, you complete it. So we don't want it to happen anymore out there. But again, substance abuse, I'm sure Dr. Wingfield sees a lot of complications of alcoholism in his world too, in cardiology. Any thoughts on that, Dr. Wingfield?
Yeah, absolutely. I'll touch a little bit also on cardiac specific screening, but I tell patients, I mean, alcohol is poison to the heart. It is toxic in several scenarios. We see cardiomyopathies where you have a reduction in your overall heart function as a result of excessive alcohol use or alcohol abuse. So it's poison, especially when you're dealing with large amounts of alcohol over an extended period of time. It can also trigger other things like electrical arrhythmias, for example, atrial fibrillation. That's where the top chamber of the heart beats irregular, puts you at risk of developing blood clots in your heart. Those blood clots tend to leave the heart, travel to the brain, and cause a stroke. So alcohol is, if you can, you really have to do without it, okay? Especially in excess. So there are some recommendations where alcohol can be helpful in terms of your cholesterol numbers, but anything in excess is certainly toxic and poisonous to the heart. So also when we look at screening from a heart standpoint, those things like the coronary calcium score, which is a CAT scan that takes about 3 minutes. That CAT scan is going to calculate how much plaque has deposited into the arteries of the heart. This is a test that I've done I've had. I recommend it to everybody over the age of 40. You're over 40, you need to get a calcium score. And if you have a family history of heart disease, you may need to get that calcium score prior to that. Now, what you get with that calcium score is a number. That number will tell you how much plaque has stuck to the arteries and caused atherosclerotic heart disease. You get a score of 0, you're in pretty good shape. The higher that number, the recommendations may change. So that is test number 1 that we strongly recommend. Also, we talk about carotid artery screening. The carotid arteries are the arteries here in the neck that if you do start to see plaque deposition in the carotid arteries, it can be an indicator for heart disease. So you see a lot of these mobile vascular clinics or mobile vascular screenings where they look at your carotid arteries to see if you've developed any plaque. Those patients or people who are diabetic, if you have diabetes and you're over 50, you should have a test called an ankle brachial index, okay, ABI. Essentially, we're comparing the blood pressure in your arms to the blood pressure in your lower extremities. The issue with diabetes is that blood sugar attacks the blood vessels and causes plaque buildup, damage to the arteries, disruptions in circulation. Problems with circulations can ultimately lead to infection, gangrene, wounds, and then amputations. So if you do have an abnormal ankle brachial index, that is a risk factor for other issues. So a lot of times we'll see an abnormal ankle brachial index and we say, well, look, you need a stress test. You need an EKG. You need a CAT scan. You need a calcium score. You need an angiogram. So a lot of times this vascular disease can be the tip of the iceberg, as we call it, where there are multiple underlying untreated disease processes that are that we need to know about to prevent long-term issues. And the last thing I'm going to state is those patients who do have that family history of heart disease, beyond the calcium score, there are blood tests that we look at, these inflammatory markers that will indicate your risk, and we use that to risk stratify. So if you have these markers, lipoprotein little a, ApoB, these additional markers, a high sensitivity, a CRP, if your CRP level is elevated, those are markers that indicate increased risk of heart disease. So your cardiologist will order those additional tests that you may have outside of your initial set of blood work. And then finally, just from the HIV standpoint, just because your blood work is okay, doesn't mean you don't have HIV. So a lot of people, they'll say, well, my blood work was good, so I guess he checked it. I guess my doctor checked it. So just because your physician sends blood work, it doesn't mean that they did screen for HIV. So I know that point was made, but some patients do think in that mode.
Wow. Wow. If we're at that time already, we're about to run out of time, man. And, you know, we had a very lively discussion tonight. And I want to take a one quick minute to talk about one thing we did not talk about tonight, and that's Esophageal Cancer Awareness Month. This particular month is Esophageal Cancer Awareness Month. And I want to say that because, you know, cancer treatment has come a long way, you know, where we used to say that, you know, if you had esophageal cancer or if you had multiple myeloma, whatever, your chances of surviving past 5 years are very, very small. Now, esophageal cancer is not a total curable disease, but it's very, very treatable this day and age. So you want to be aware of your symptoms, like, you know, what are your risk factors for tobacco use, alcohol consumption, drinking hot and soft carbonated drinks, eating pickled vegetables, low intake of fresh fruits, using a lot of Motrin-like drugs. And if you have really, really bad gastroesophageal reflux, where you get something called Barrett's esophagitis or Barrett's esophagus, can lead to esophageal cancer. And poor oral health in and of itself can give you esophageal cancer. So some of the symptoms are weight loss without trying, chest pain, worsening indigestion or heartburn, and coughing or hoarseness. So if you got any of those symptoms and you have a family history of any type of head and neck cancer, please be aware of it and discuss it with your doctor. So we're going to take these last few minutes and we're going to everybody give a 30-second closeout, and we'll start with you, Dr. Ford.
Well, I think we had a robust discussion this evening, and I think that, you know, the important thing is to make sure that you follow up with your primary care doctor, internal medicine, family practice, pediatrician, and that way you can get some continuity of care. You have somebody who's following all the tests that you may need and be able to guide your care. So again, I thank you for having me. And it's always good to be amongst the Omega men who are making a difference in the community.
Thank you, Dr. Ford. Dr. Plummer.
Good evening. It was great being surrounded by these doctors and having a robust discussion. The main thing I just want everybody to know is to make sure that you go to your primary care, physician. Don't be afraid of going to your primary care physician. Make sure that you have a dialogue with your doctor and that you feel comfortable, expressing everything and your concerns to your doctor. And as we always talk about it all the time, prevention, and immunization. Thank you.
Thank you, Dr. Plummer. Dr. Isabell.
Once again, it's a pleasure to be on with my brothers for giving medical information, education. Primary care doctors think them as the gatekeepers. They can help you get access to even specialists, preventive care. One last point before I leave regarding esophageal cancer, to add high concentration of alcohol as well as smoking greatly increases your risk of esophageal cancer also. And regarding diabetes, symptoms everybody should know: if you're thirsty a lot, you could be urinating a lot, fatigue, dry mouth, even numbness and tingling of your hands, your feet, those can be signs of diabetes. Once again, it's a pleasure to be here. Thank you.
Thank you, Dr. Isabell. Dr. Wingfield.
Thank you. Once again, it was a pleasure to be here. I truly enjoy these exchanges. I glean a lot from it and learn a whole lot from these talks. So my closing points would be certainly prepare yourself for your visit to your primary care physician, your specialist, but take a few minutes, write down a few questions, understand your symptoms. Think back, wow, this actually started 6 months ago versus 6 days ago. Really try to understand and articulate what are the issues. And a lot of times you get to that doctor's visit and your mind can go blank. So that's why write down the symptoms, write down your questions. As Dr. Ford said, take pictures of your medications, bring those medications in, but we truly have to go in and be our own advocate. Ask those questions, expect the physician to answer those questions. And a lot of times ask open-ended questions. A lot of times a patient will say, was my EKG okay? Or a better question is, what did my EKG show? Or are there any changes in my EKG? Or what did my echocardiogram show? What were we looking for? When you order this test, what are we looking for? You want me to get a stress test? What are we looking for? What can this test, or what's the next step beyond this test? So I think if we are more in tune and more active in the process, the physicians are certainly going to respond appropriately. And also another thing, younger family members, please take your elderly family members or parents or older loved ones to their visits so that you can be an advocate for them. And then finally, prevention is the key. So really take the reins and be an advocate for your health. And I look forward to next month. And thank you very much for having me.
Dr. Guyton.
I love coming behind Dr. Wingfield because I write down everything he says because I've learned a lot. Calcium, I'm going to get my calcium score. Brothers, is again a great honor to be here with our second district brothers and everyone out there. I really want to thank you all. As a pharmacist, I really come into this conversation to kind of, complete the continuum of care. Our specialists, our doctors are highly educated, and our patients have got to understand that they're there to support them and to help them. So advocate. The biggest thing that I've gotten is that now, as my 71-year-old mother, she understands how to find information about her medications and what to ask her doctor. What services do she question when she goes there? She writes a journal. All that comes because of she had a advocate in the household, me. Not everyone has that. So it's important that as a community, we develop resources to increase the health literacy within our minority communities because they need to advocate for themselves. They need to ask the questions. Keep a journal. Ask the open-ended questions. Have the conversation with your provider. Don't let it be just one way. Thank you again for allowing me to be here, brothers.
Thank you. Dr. Phillips, take us home.
Well, again, I just want to thank you, brother Dr. Guyton. No, Dr. Boykin, for stepping in for our normal moderator. I appreciate you being flexible and capable, my brother. I want to thank our second district representative, Brother Delrico Gales, for his consistent support of our initiatives. And I ask each of you in the audience, please continue to attend and watch our monthly webinars, which come on the last Wednesday of the month at 8:15, where we discuss a variety of topics that discuss or surround, the advocacy of improving health in African-American communities. What I would say pertaining to tonight is prevention costs you a whole lot less than reaction. When you have a primary care physician, it allows you to develop a plan to work on the things that you need to work on, but also it gives you a space where if you needed to enter the medical system, you enter it from a more efficient point, where you don't waste time, where you don't have those experiences, which in the past, because of maybe entering the medical system with a problem at an inefficient point, such as the emergency room, you spare yourself that frustration because unfortunately, as we've discussed in multiple moments tonight, that frustration can be the thing that makes people say, I'm not going back to the doctor's office. So again, thank you, my brothers, for participating on the panel. And thank you for those in the audience for being part of our presentation tonight. Thank you.
And there you have it, folks. We certainly enjoyed presenting to you guys tonight. We hope you come back next month for our next edition of our monthly webinar. And again, please take time to give blood. It's a life-saving effort that you can do. Be aware of the cancers that are out there. And by all means, have a great night. Thank you very much.